Okay, hi everyone, it's Zach. Um, this is my case presentation on shoulder rehab for rock climbers. Okay, case description. It should look pretty familiar. 25-year-old male with a 5-year history of right shoulder pain during exercise. He's a gym goer and climber. Only feels pain during his exercises. He feels he's overcompensating with certain muscles, slight instability, pain with push and pull exercises. It's got 0 out of 10 pain at rest and up to 3 out of 10 pain during recreational activities. Pain is limiting ADLs, but at the time of the eval, he's feeling his shoulder when carrying like laundry up the stairs, for example. Not doing anything to manage his pain right now, kind of just pushing through it. And the goals are symmetrical function on both sides of the body and to be able to participate in recreational activities pain-free. Objective, range of motion, flexion 160, abduction 160, internal rotation 50 and painful. Passive range of motion beyond these is painful, otherwise within normal limits. Strength 4 to 5, shoulder flexion, abduction, extension, elbow flexion, middle lower traps, external rotation and internal rotation 4- out of 5. Cervical spine cleared. Accessory motion, hypomobile CPAs T4 through 9, posterior glide hypomobile, first rib hypomobile. Palpation, tenderness to upper trapezius and first rib. Special tests, Neers Hawkins, grade 1 load and shift, grade 1 sulcus, and he experienced scapular dyskinesias during overhead like flexion, abduction, scaption. In terms of an outcome measure, he was 8% disabled on the Spotty. And additional ICF components I didn't mention. He works from home. He does IT for the last like 6 to 8 months after graduating from undergrad. He's got a supportive family who he lives with, and seems like a good group of friends. He's always had a positive attitude with regards to rehab. The only negative thing is the chronicity of his injury. Okay, so Zach, why are we doing this case again? When I was the group lead, it helped me understand the diagnosis of subacromial pain syndrome, which is what we diagnosed him with. No, it's not a great diagnosis. Kind of wanted to further dive into this case because we've kind of thrown the book at him. We've been seeing him, I think, since week 2 of this rotation. We've made some progress, but it has been relatively slow. Some things that we've done: thoracic spine, manual therapy, posterior glides, passive range of motion, muscle energy, first rib mobs, STM, ICI, dry needle infraspinatus, upper trap. In terms of exercises, we've done open chain stuff, lower level, moving into higher degrees of abduction for like rotation. We've strengthened up scapula. In terms of motor control and strength, closed chain stuff was tolerated a little bit later. Done body blade, thoracic mobility, rotator cuff endurance and strength, serratus, bicep, isometrics, and eccentrics. Again, progress has been slow and feels like it's felt like he's kind of just feeling his upper trap and his anterior shoulder kicking in during these higher level exercises. So due to the fact that climbing requires significant demand on the entire upper extremity and is a closed kinetic chain exercise, I kind of wanted to dive into the research to see if there's any ideas on how to better tackle this patient case. And kind of in the same vein, want to go beyond just treating impairments that I find. So we land on this PICO question. In a 25-year-old male rock climber with right chronic shoulder pain, how do open chain exercises compare to closed chain exercises in helping return to climbing? So literature search was tough. Obviously, don't expect to just type in your question and find the perfect article, but there aren't too many articles specific to climbing rehab at all. Adding in the chronic piece is a whole nother element. So I decided to broaden it up to overhead athletes, which is something that we can talk about as this goes on. And I felt like it was a reasonable thing to include. So I found a couple articles and we can talk about those. So this first one, I had to translate from Ukrainian. So we'll talk about it. So basically 44 in the experimental group, 40 in the control group, male young climbers. Basically, they randomized the athletes into two groups. There weren't any differences at baseline, body length, body weight, climbing experience, or number of injuries during the 6-month period before they started this trial. So they just tracked injuries as people were climbing. And then both groups did some sort of exercise that I'm not sure and exactly what it was extremely unclear. But then the experimental group did closed chain exercises and open chain eccentric exercises. And over the course of that year, they tracked the incidence of injury. So over the course of the year, there were 21 injuries in the control group that was doing some sort of exercise. I think it might have just been their climbing training, and then only 3 in the experimental group. So there was a significantly reduced incidence rate ratio here. In terms of external validity to our case here, it's looking at injury prevention, not rehab. Also, in terms of reproducibility of this study, there's no standardization for interventions. They just said they were doing closed chain exercises. So they said, okay, we're exercises such as push-ups or pull-ups or assisted pull-ups or even just wall hangs off the climbing wall. So there was no standardization at all for any of that. Another thing they emphasized was cueing of proper form during kind of climbing. So they might have been cueing during climbing for this, the experimental group. It's really focusing on scapula retraction and depression. Again, nothing standardized here. One last thing on this one, they emphasize trunk and abdominal stability being key for climbing, which is something that I knew, but never really kind of addressed or thought about with this patient that I worked with. The next article here wanted to look at the best evidence for exercise prescription when treating shoulder pathology in the overhead athlete. So I was really interested in finding this one. It was a systematic review. And I feel like that's a pretty broad question. They kind of, some of the mesh terms they used were baseball or volleyball or softball or tennis or swimming. So that's how they defined overhead athlete. Kind of the next article, we can dive into that more. I thought their exclusion criteria was sufficient. Cadaver, non-human studies were excluded. Studies were excluded if patients had history of stroke. Exercises intervention was not described in sufficient detail. So I felt like I was happy with that. There was a risk of bias assessment. And then they also did a best evidence synthesis to like essentially grade the level of evidence. And they used the CEBM, so the Center for Evidence-Based Medicine, to synthesize the data because a lot of the studies that they identified were based off of expert opinion pieces. So more on that later. So in terms of results, they found 39 studies, 33 of which were based off of expert opinion. There was 102 exercises that met the criteria, and most of them were single plane upper extremity exercises below 90 degrees of elevation. So the strength of the recommendation for these, there was only 2 types of exercise that got B, and that was the highest level. So it was open single chain and closed chain upper extremity. So essentially more early stage rehab. Advanced, intermediate stage were unclear, low quality evidence. And all the expert opinion is low quality evidence as well, because they're kind of just basing it off of their own experience, which is interesting. None of the studies looked at return to play outcomes for any of it. And there was one quote that stood out to me from this article says there is limited evidence to support the use of any specific exercise intervention in overhead athletes undergoing rehabilitation for shoulder pathology. So shows that we need better studies, continue working, stuff like that. There was an emphasis for a full body approach with this one as well, just because of the different, tasks that are required for all these different exercises, or not exercises, sports. And then also what I found interesting was plyometric exercise was also D-level evidence. But we know that as we kind of move through rehab, we do plyos and we do return to sport stuff. So there's a disconnect there, because my understanding is that stuff works, but it's not supported by the evidence. Another thing to consider is that this article was published in 2017, so there might be some better articles that have been published more recently that better kind of guide us. And then here is a list of exercises from the study from the 6 articles that were not of expert opinion. You can see how the different exercises there's some carryover between the different studies. This last one. Okay, so this is a slightly different one. So they looked at whether manual therapy and progressive resistance exercise versus motor control exercises in improving muscle isometric strength. Pretty straightforward. Randomly divided into 2 groups. No differences at baseline. Pre and post assessments were blinded for assessment. And there were participants from a wide variety of sports that were considered overhead athletes, specifically specifically adding to the ones that we talked about before, baseball, swimming, stuff like that. You could say they said badminton, basketball players are overhead athletes. So I feel like it's pretty reasonable that climbing is considered an overhead activity with this criteria. The thing that I liked about this article was that they did these exercises for 8 weeks, 2 groups doing, like I said, motor control exercises that essentially stayed the same and progressive resistance exercises. They added in closed chain exercises on the last 2 weeks. So that made sense to me in the context of my patient case, because he was really only able to tolerate those closed chain exercises without pain in the more recent weeks. This, is because of the increased load required during closed chain exercises on the entire, not only the glenohumeral joint, but the entire upper extremity and the co-contraction of those muscles. This article also really talks about the emphasis of upper trap and anterior deltoid overcompensation with this subacromial pain syndrome. So that's something that really kind of connected the dots a little bit here. One thing with this article, in terms of external validity, it didn't look at return to sport. It looked at isometric strength. Again, we talked about what is an overhead athlete. And then in terms of chronicity, the people they got for this study were anyone who has experienced shoulder symptoms that they could classify as subacromial pain syndrome greater than 1 month. So there was no kind of upper boundary there. So you're kind of in different stages of healing. Okay. In terms of application of the evidence and answering my question, absolutely going to continue to use open and closed chain exercises. It's pretty clear from the second study that the basics are pretty well backed in the evidence. So ER at the side, prone extension, stuff like that. And then adding in closed chain exercises is tolerated. Again, we kind of talked about the emphasis of full body during sport-specific training. There's not great research to support it, but I think for climbing, it's clear that abdominal and lower extremity strength is necessary to kind of offload the shoulder. In terms of patient values, kind of became more clear that his strength training was more in supplementation for his climbing, not the other way around. I kind of focused more on lifting movements and movement analysis there and tweaking form there, but I didn't really look at his climbing, kind of still working through how I could do that in my head. And again, like with all these exercises, like he's in a low level of pain, he could push through and complete the exercises, but he doesn't want to do that anymore. And we want to reinforce, exercise without pain. And then from my own very limited clinical experience, working through impairments and addressing movement patterns has kind of worked. And especially in this case, we kind of identified the scapula was kind of our first place to work. We worked on motor control, we worked on strength, and that kind of cleared up. And we're still experiencing some of that upper trap and anterior deltoid kind of overcompensation, over activity. We're working through that now. We're still making progress. Chronic shoulder pain is kind of going to take longer than the acute shoulder pain that I've found in clinic. And that's just something that I just have to be ready to accept and be able to educate on. And then just trying things out in terms of progressions and regressions. If someone's ready for something, it'll be clear, especially with him, because we kind of were trying to make it so that he wasn't having pain during any of his exercises. Moving on. What I could do differently, probably overdid the manual, spent a good amount of, each session working on that. But with the chronicity, I think he just would probably benefit from just exercise. But I do think there's value in kind of putting hands on people and making them feel like I'm actually doing something. Another thing is I would want to look at abdominal and lower extremity exam and then exercises if there was deficits there to kind of, like I said, offload the shoulder. I kind of focused, like I said, exercises about like returning to gym versus returning to climbing. That's something that, just maybe better communication, really identifying goals, diving deep into exactly what he wants. And then kind of, like we said, it's kind of difficult to look at climbing form, but I really haven't seen him do a pull-up. I've just kind of done part practice with that, with like almost like a TRX row, but I haven't seen what his scapula does when he does a pull-up. So that's something that I could identify as well. It's important to identify that he has made progress. His SPOTY score has decreased. It was pretty low to begin with. He's back to climbing some easier routes, but he's not doing rope climbing yet. And it's kind of identified that working with this athletic population who's kind of pushed through injury and it's been chronic and it's been years is pretty difficult to kind of tease out everything, and it might take some time. And then in terms of my own knowledge, like I feel pretty good, like breaking down a squat or a deadlift or other compound exercises like that. But I'm not sure that I could observe someone climbing and do a movement analysis and say, okay, you're not using your legs enough, or when you're hanging there, you need to be doing this. Just because I'm not a climber and I haven't really, done enough research with that. So there's always more to learn. And yeah, it's exciting to kind of have the opportunity to always kind of learn new things. So that is what I have, and I'm excited to see what you guys think.